So we've titled this Nitric Oxide, How Not Enough Relates to Cardiovascular Disease and really any age-related disease. And I want to thank FullScript, a wonderful partner on providing education and a platform for our product technology to all healthcare practitioners. And so a little bit about me, I've spent the last 20 years in academia and really studying nitric oxide. And about 20 years ago, shortly after the Nobel Prize was awarded, my research program really developed four main priorities. Number one is, how does the human body produce nitric oxide? What goes wrong in people that can't make nitric oxide? What are the clinical consequences and what do they present with in the clinic? And then perhaps most importantly, how do you fix or restore endogenous NO production? And I'm proud to say that we've answered those four basic questions, and that's part of what I want to do today is provide you the answers to those four very important questions, and how then you can implement that into your patient practice and actually see right before your eyes your patients get better. Even your most complex patients, and every physician, healthcare practitioner has that one patient that's a mystery that you can't figure out. No matter what you do, they can't seem to get better. And so this is really eye-opening for me, and hopefully it'll be as gratifying to you as it has been for me in the past 20 years. The result of all this, I have dozens of issued U.S. international patents on nitric oxide technology, published over hundreds of peer-reviewed published papers on nitric oxide, and I've given over 200 lectures worldwide on nitric oxide. So I've spent my entire career doing this. So I think I understand really the enzymology and biochemistry of nitric oxide. I don't expect you to, because it's really a very complex, complicated science. But most importantly, I want to give you a working conversational understanding of nitric oxide. So when your patients come in and they're asking you questions about nitric oxide, that you have the education and information to answer them, or you can then provide education to your patients so that they can understand the importance of nitric oxide. I'm required to disclose these conflicts of interest. I'm a founder and shareholder of Human to the Power of N, and you can read through those now. And the University of Texas Health Science Center at Houston owns many of my patents, and I receive royalties from sales and licensing of those patents. So to kind of reiterate this, I just want to teach you the nitric oxide signaling in the human body, what goes wrong in people that can't make it, how this contributes to health and disease, recognize the clinical symptoms that result from lack of NO, and then reveal evidence-based therapeutic and nutritional strategies to restore NO production in patients. And this has been my guiding principle, because I'm not a physician, I'm a basic scientist, but my job is to provide you as clinicians the tools that you need to treat, diagnose, and prevent disease. And so my job is to see what everyone else has seen, but to think what no one else has thought. And this is by 1937 Nobel Prize winner Albert Svent-Georgi. And I just want to start out that no matter what imaging modality or diagnostic tool you use, they all have one common denominator. And if you look, I'm a big fan of Daniel Amen, and if you look at what he's done in SPECT scanning, you can look at it really shows perfusion of the brain. And whether you've got post-concussion syndrome or this chronic brain injury from blast trauma, or you get alcoholism or ADHD, they all show hypoperfusion to certain regions of the brain, where a healthy brain on the left side shows that the brain is very well perfused, both macro and micro vessel circulation. But the abnormalities of any condition is really lack of blood flow to that particular organ. And I think it can be argued that every single chronic disease is characterized by decreased blood flow to that affected organ or tissue, whether it's erectile dysfunction or whether it's ischemic heart disease and angina, whether it's vascular dementia or diabetic neuropathy or macular degeneration. It's all reduced blood flows. There's a vascular component to every human chronic disease. And if you can restore blood flow and perfusion to those specific tissues and organs, you can correct many of these chronic pathological conditions. So the fundamental question you have to ask yourself as a clinician is, how do you restore blood flow and perfusion to these select tissues throughout the body? Well, you can do that through this molecule called nitric oxide. And that's what I want to spend the next 45 minutes on, is really giving you the ins and outs of nitric oxide, how it's produced, and really put to bed some of these myths, because there's lots of nitric oxide product technologies on the market. And 99% of them don't work. So I'm going to save you some money in this process by not wasting your money or sending your patients by buying inferior products. And this was the front page of the New York Times the day the Nobel Prize was awarded in 1998. The discovery of nitric oxide and its function is one of the most important in the history of cardiovascular medicine. That was by Val Fuster, who was president of the American Heart Association at that time. And at the time that nitric oxide was discovered, and even when the Nobel Prize was awarded, it was thought that it was simply a vasodilator, that it dilated blood vessels and managed normal blood pressure and improved oxygen and nutrient delivery to every cell in the body. Well, now we know from this study several years ago by Jonathan Stamler that nitric oxide is actually required for oxygen delivery from hemoglobin to the periphery. So if you remember the cardiorespiratory cycle from your physiology and biochemistry from many of you years ago, you remember, and a lot of this is called the Bohr effect. So when the blood, the hemoglobin goes from the arterial circulation to the venous side of things through the capillaries, hemoglobin undergoes this allosteric transition from R to T. And during this transition, it offloads oxygen and picks up CO2. Well, the oxygen will not come off of hemoglobin unless nitric oxide is bound to a single cysteine residue on that hemoglobin. So if your patients are chronically nitric oxide deficient, there's no nitric oxide bound to cysteine, so you can give them 100% oxygen through a nasal cannula, and you can get their O2 sats up to 98, 99%, but systemically they're still hypoxic because the oxygen will not and cannot come off hemoglobin until you restore the functionality of nitric oxide. And so not only is nitric oxide a vasodilator, but it's a signaling molecule that basically controls protein structure and function. Just so happens one of the most important structural and functional proteins is hemoglobin in the delivery of oxygen. But we know it's more than that. It's involved in every biological function, from maintaining the integrity of the cardiovascular system to maintaining gut motility in the peripheral nervous system. It's the requisite molecule that tells our own stem cells to mobilize and differentiate. So the older you get, the less you heal. Your stem cell function becomes less. Why? Because you make less nitric oxide. It's a neurotransmitter in the central nervous system. It's produced by our neurons. It's involved in a retrograde memory and learning. It controls cell cycles, so an important component in cancer cell proliferation. It's a smooth muscle vasodilator in the respiratory tract. Asthma patients generate less nitric oxide. That's why there's vasoconstriction in the bronchioles. It's the molecule responsible for erections in both men and women, and it's part of our immune function, our innate immune system. It produces nitric oxide to kill viruses, bacteria, fungal infections, basically any pathogen that the body sees. It's designed to generate a lot of nitric oxide in a short amount of time to kill these pathogens. And as I mentioned earlier, the Nobel Prize in 1998 was awarded to Bob Furchtgott, Lou Ignarro, and Fred Murad for their discoveries as nitric oxide is a signaling molecule in the cardiovascular system. And it was Fred Murad who discovered that drugs like nitroglycerin worked because they were metabolized into nitric oxide. So these drugs were used 150 years prior to the 1970s for the treatment of acute angina. Physicians used these drugs because they worked, but no one knew why they worked or how they worked. And it was Fred who discovered that organic nitrates are metabolized into nitric oxide to get coronary vasodilation and relief of the ischemic pain known as angina. And then 3 years later, in 1980, Bob Furchtgott discovered that our endothelial cells, the cells that line all blood vessels and lymphatics throughout the body, produce a substance that causes these blood vessels to relax and dilate. And he termed this endothelium-derived relaxing factor, or EDRF. And then 7 years later, in 1987, Lou Ignarro discovered that EDRF is nitric oxide. So the story then, and still today, is that if you stimulate endogenous NO production through the endothelial cells or give an exogenous NO donor, whether it's organic nitrate or some other nitric oxide technology, it causes smooth muscle relaxation, vasodilation, improvement in circulation and blood flow throughout the body. And I've been fortunate to work with all three of these. Bob Furchtgott passed away many years ago, but Lou Ignarro has written the foreword to several of my textbooks, and it was Fred who recruited me to join the faculty of University of Texas Medical School in Houston almost 15 years ago. And so a lot of the work we did early on at the University of Texas was with Fred as my department chair, with really a drug discovery program we had in place, trying to find either small molecule activators or stimulators of nitric oxide, or, as I'll show you, ways that we could basically recapitulate nitric oxide based signaling. So as a clinician, you may ask yourself, who needs nitric oxide? And I'll convince you by the end of this that it's all of these people. Anybody who's aging, certainly anybody over the age of 40, people with circulatory issues. So if they're in your office with a chief complaint, they probably have vascular issues. Diabetics, I'll show you how nitric oxide is involved in insulin signaling and glucose uptake. People with low energy, chronic fatigue syndrome, nitric oxide controls and regulates mitochondrial ATP production and mitochondrial biogenesis. People with sexual dysfunction, that's both men and women. The loss of regulation of blood flow to the sexual organs is the first sign and symptom of problems with nitric oxide production. If you have vascular dysfunction in the sex organs, you have vascular dysfunction in the coronary arteries, the cerebral arteries, every artery in the body. It just so happens loss of regulation of blood flow to the sex organs is a really inconvenient symptom to have in many times. Anyone on antacids, proton pump inhibitors, over 200 million Americans take these every day, completely shuts down nitric oxide production. From my perspective, if we do our job and educate you as clinicians and patients and consumers on the importance of nitric oxide, if you can understand what your nitric oxide production rates are, and then employ these strategies that I'm going to teach you to prevent this age-related decline in nitric oxide production, you can prevent age-related disease. Anyone eating a poor diet, and I'm going to show you some really cool non-invasive FDA-cleared medical devices, anybody with vascular dysfunction, and I'll show you how to turn that around. But I'm going to take you back to a very simple concept from many centuries ago, that a man is as old as his arteries. And this is illustrated here because it's known that the older we get, our blood vessels become stiffer, plaque-ridden. You see this plaque that begins to occlude the lumen of the blood vessel. And you can show this on an angiogram that there may be 90% occlusion in that artery, but it's really not the occlusion or the stenosis that's causing the problem. It's the vulnerability of the plaque. And that is due to inflammation and immune dysfunction. So you've got people with 90% stenosis of the coronaries that do quite well. You got people with 10% stenosis that die of sudden cardiac arrest because even that little bit of plaque there was a vulnerable plaque, and it ruptures and causes sudden cardiac arrest. So it's not just the degree of plaque formation in the lining of the blood vessels, it's the vulnerability of the plaque. But regardless, the more you have, the less blood flow you have through the coronary arteries, or any artery for that matter. And so we were interested to figure out, where does nitric oxide play in this entire sequela of events, from the onset of fatty streaks to the end result of myocardial infarction. And that's illustrated here, that when you're young and healthy, your endothelial cells make sufficient nitric oxide that prevents the inflammation, oxidative stress, and immune dysfunction that occurs with cardiovascular disease. But the older we get, the more endothelial function we have. And in fact, the loss of nitric oxide production, the functional loss of nitric oxide production, precedes the structural changes in the lining of the blood vessel by many years, sometimes decades. So that's why I think it's very important for people in their late 20s, early 30s to begin to utilize these FDA-cleared medical devices to get a sense of their nitric oxide production, endothelial health, endothelial function. And then if they're compromised in any way, then take the steps to restore nitric oxide production to prevent this whole fat deposition, inflammation, oxidative stress, and immune dysfunction that causes heart disease and eventually heart attack and stroke. So the fundamental question then we asked was, if this is so important, then how do we control and regulate nitric oxide production? And in 45 minutes, I can't go through the detailed biochemistry, but suffice it to say that there's two ways the body makes nitric oxide. And one can compensate for the other. And through stoichiometric radio-labeled isotopes, we've begun to understand that each pathway provides about 50%. So the first pathway to be discovered was through the oxidation of arginine by an enzyme called nitric oxide synthase. The other, more recent pathway is through the utilization of the diet. So plant-based diets, green leafy vegetables, are enriched in inorganic nitrate. This is unlike organic nitrates like nitroglycerin. These are naturally occurring inorganic nitrate that's found in soil. So any vegetable that we eat that's grown in soil providing a source of nitrate. And then this is serially reduced, or can be, all the way down to nitric oxide to provide vasodilation and protection from cardiovascular disease. But if we look at the endothelial, the NOS production of nitric oxide over time, you see that endothelial function decreases with age. So by the time we're 40 or 50 years old, we only have about 50% of the nitric oxide we had when we were younger. So giving L-arginine-based products to an older population makes no sense biochemically. because they're not deficient in arginine. They simply lost the ability to convert arginine to nitric oxide. So giving more will not fix this. In fact, it can actually make patients worse because long-term outcome studies in post-infarct patients and patients with PAD, patients actually got worse and actually died at a more rapid rate by giving arginine. So you can't be so naive to think that this is an arginine problem. And I'll show you enzymatically and genetically the role of arginine in nitric oxide production towards the end. But this is how things are designed to work. So if you can appreciate that this pink would be the lumen of a blood vessel, that would be the blood. This is the single layer of endothelial cells that line all blood vessels throughout the body. And then underlying those endothelial cells is the smooth muscle. So when smooth muscle relaxes, it dilates the blood vessels. So when we begin to exercise, this causes shear stress in the lining of the blood vessel that activates an enzyme called nitric oxide synthase. If this enzyme is coupled and functional, it converts arginine, the guanidino nitrogen of arginine, through a 5-electron oxidation into nitric oxide. And then you get citrulline as a byproduct. Well, nitric oxide is a gas, so it diffuses in 3 dimensions. So part of it diffuses in the lumen of the blood vessel, and I'll show you a video later how it interacts with platelets and monocytes and neutrophils. But part of it diffuses into this underlying smooth muscle where it binds to an enzyme called guanylyl cyclase. And this is the enzyme that Fred Muir had worked on for 30 years, in fact, his entire career. This enzyme converts GTP into cyclic GMP, and this is responsible for the smooth muscle calcium-dependent relaxation. And some of you are familiar with this pathway because this is the site of action for PD5 inhibitors, such as Viagra, Cialis, and Levitra. So nitric oxide increases cyclic GMP production, and PD5 inhibitors, such as Viagra, prevent the breakdown of cyclic GMP. These are very successful drugs, obviously, been on the market for more than a decade, but they only work in about 50% of the men. So this told us that erectile dysfunction isn't a problem with overactive phosphodiesterase, it's insufficient nitric oxide production. So if you don't generate enough nitric oxide here, you don't get any cyclic GMP produced here, so these drugs cannot and will not work. In fact, that's the reason they're non-responders to PD5 inhibition therapy. So if you restore nitric oxide production here, you can turn non-responders to PD5 inhibition therapy into responders and actually titrate the dose down of these drugs to make them safer because you're basically priming the pump, if you will. And then the question became, can proper nutrition, food, or supplements provide nitric oxide support? And I'll just take you back to really grade school biology and the atmospheric nitrogen cycle. So the air we breathe is 78% nitrogen. This nitrogen is fixed primarily through lightning fixation, or they're nitrogen fixing bugs and bacteria in the soil that then fix nitrogen into ammonia or nitrite or nitrate. So any plant that we eat that's grown in the soil, we're getting a source of nitrate and nitrite, or any animal that we may eat that's eating the grass or the vegetables and we consume these animal proteins or meat, then we're getting a source of this through our diet. And just as there's a nitrification cycle in the soil, there's a denitrification pathway in humans. So when we eat, for instance, a green leafy a spinach salad, that the nitrate that's concentrated in these green leafy vegetables are taken up in the duodenum and concentrated back in our salivary glands. So each time we salivate, this secretes nitrate into the oral cavity. They're nitrate-reducing bacteria that live in the crypts of the tongue that perform this 2-electron reduction of nitrate to nitrite. And if we swallow our own saliva, which is then enriched in nitrite, not nitrate, the pKa of nitrite is 3.4. So provided that our stomach can make sufficient stomach acid, nitrite becomes protonated and generates nitric oxide gas in the lumen of the stomach. And the nitric oxide that's produced from swallowing our own saliva in an acid environment of the stomach kills foodborne pathogens from Clostridium to H. pylori, the ulcer-causing bacteria, enhances gastric mucosal blood flow, enhances nutrient absorption, micronutrient absorption, trace minerals, and prevents gastric ulcerations from chronic NSAID use. So a basic fundamental physiological role for eating green leafy vegetables, having the right oral bacteria, and having sufficient stomach acid. And I'll show you how we as Americans disrupt this pathway by what we do. And this shouldn't be a foreign concept because we know that food is medicine and medicine is food. So we did a literature review, because by then there were lots of studies coming out that you could take beetroot extract or beetroot juice and see changes in blood pressure or improvement in exercise capacity. Most Olympic athletes are now using our concentrated beetroot powder. But the literature showed us that we needed 300 to 400 milligrams to see changes in this. But if we look at food consumption tables and estimate nitrate content of the standard American diet, the SAD diet, we're only getting about 150 milligrams of nitrate per day, and that's over 2 to 3 meals. So just as most Americans are deficient in magnesium, vitamin D, many other trace minerals, chromium, selenium, we're deficient in nitrate. And if we look at different dietary patterns, the DASH diet, we published on this probably 10 years ago. The dietary approaches to stop hypertension works because it provides sufficient nitrate that if your body has the right bacteria and sufficient stomach acid, can generate nitric oxide and manage blood pressure. Same thing with the Japanese diet, even a vegetarian diet. But if you look at the US diet, it's the lowest in there. We have the poorest health outcomes of any population on the planet. And then the next question was, if we wanted to change guidelines, so I look at this from really a public health perspective, that do we need 3 to 5 servings of vegetables a day, but how much of these vegetables would we need to consume to get enough nitrate that if all mechanisms were in place, we could manage blood pressure? So we went to 5 different cities across the US, and we just took broccoli, cabbage, celery, lettuce, and spinach from Whole Foods in Chicago, Dallas, Los Angeles, New York, and Raleigh. And we published this back in 2015. But if let's just take celery, for example. So if you lived in Dallas or Los Angeles, you could eat about 6 to 7 stalks of celery and get about 300 to 400 milligrams of nitrate in that celery. However, if you lived in New York, you'd have to eat about 87 stalks of celery to get sufficient nitrate to lower your blood pressure. Same thing with, look at cabbage and broccoli. So there are regional differences in nitrate accumulation in vegetables. And this is conventionally grown. If you look at organically grown vegetables, there's about 10 times less nitrate across all vegetable categories. So organic is good in the fact that you're not getting exposed to herbicides or pesticides, but you cannot eat enough organic vegetables to get sufficient nitrate to lower your blood pressure. The other consideration is that nitrate is inert in humans. Humans cannot metabolize this enzyme or this molecule. And so what happens is, and there are nitrate-based products out there, that you're given an inert compound to humans. So this is 100% dependent upon oral bacteria. Humans cannot do this. And the statistics are very clear. There are 200 million Americans that use mouthwash every day. Another 200 million Americans use antacids every day. And there are over 200 million prescriptions for antibiotics given every year. This is more than almost twice the population of America. So the majority of Americans can't even utilize the nitrate they get from their diet. The damn sure can't utilize nitrate that's given in the form of a capsule, because until we change our habits, we're disrupting our own ability to generate nitric oxide. So plant-based diets or potassium nitrate-based products will only work in less than 1/3 of Americans due to simple lifestyle habits. They're using antiseptic mouthwash, using antacids, or they're taking a prescription antibiotic. And the importance of this is revealed here, that if you take normal-intensive patients and you give them a mouthwash for 7 days, their blood pressure goes up. I mean, this is remarkable. 2 out of 3 people in America have an elevation in blood pressure. 200 million Americans, roughly 2 out of 3, are using mouthwash every morning, getting up and using mouthwash. So this explains a lot of things. It explains resistant hypertension. It explains the 2 out of 3 Americans that have either pre-hypertension or hypertension. And this is a nitric oxide related effect because plasma levels and saliva levels of nitrite and nitrate go down. Systolic blood pressure goes up. So we begin to interrogate this pathway to try to figure out what's responsible for this. Can we identify the bacteria that are doing this? And this made sense to us because the human genome is only 23,000 genes. The microbiome, the bacteria that live in and on our body, providing 3 million gene products. And so these bacteria are designed to do things that we as humans can't do, or that we as humans have not yet evolved to do. And so we started a study in the Texas Medical Center where we did tongue scrapings of people walking around the Texas Medical Center and got an IRB approval to figure out if we could harness these bacteria and then identify them to see if people that had an elevation in blood pressure lacked these denitrifying, nitrate-reducing bacteria in the oral cavity. We published this in 2014, but we found a nice association that the patients that did the best at nitrate reduction and kind of correlated with lower blood pressure had a completely different oral microbiome than those who had an intermediate or those that could not reduce nitrate and higher blood pressures. And this was interesting that the lactobacillus in the oral cavity seems to disrupt nitric oxide production. Then we did a more systematic study because this was kind of a correlative study. We wanted to get to mechanism. And so we took really young, healthy, mainly dental students, young dental faculty, medical school faculty that had normal blood pressure, clean perio exam, no evidence of gingivitis or periodontitis, and then took their blood pressure, did baseline tongue scrapings, and then gave them mouthwash twice a day for 7 days, watch their blood pressure, and then see how this chlorhexidine treatment was affecting the oral microbiome. And what we found was shocking, that we could identify certain bacteria that disappeared when blood pressure went up and the bacteria that reappeared when blood pressure normalized. And in one kid, 21-year-old dental student, 1 week after using mouthwash, his blood pressure went up 26 millimeters of mercury. So think about this. You take a 21-year-old kid, well-trained athlete, cyclist, not overweight, non-smoking, best shape of his life, and in 1 week made him clinically hypertensive by giving him mouthwash. And we did a full genomic analysis, and so these bacteria were expressing nitric oxide producing genes. And this is what the statisticians sent back, that we could predict steady state blood pressure either before or after mouthwash use by the presence and number of these 4 bacteria. So now we're developing hopefully some rapid diagnostics for the presence or absence of these to explain resistant hypertension. So resistant hypertension occurs because patients don't respond to standard antihypertensive medications, which are typically ACE inhibitors, beta blockers, and diuretics. Well, the source of the hypertension is an oral dysbiosis. It's not a renin-angiotensin problem. It's not an angiotensin converting enzyme problem. It's not a fluid imbalance. So of course they're resistant to those therapies because that's not the source of the problem. You have to restore the oral nitric oxide production. And let me just spend a little bit of time on diabetes because it's a growing epidemic, not just here in the US, it's worldwide. And we've known for a number of years that when you get diabetes, you get increased oxidative stress, advanced glycosylation end products, hyperglycemia, hyperinsulinemia. All this downregulates nitric oxide production, and you decrease nitric oxide availability. And people don't die of diabetes typically, they die from the vascular complications of diabetes. And so interestingly, if you knock out the nitric oxide synthase gene in mice, their first phenotype is insulin-resistant type 2 diabetes. So this mimics, the best way to mimic diabetes is to shut down nitric oxide production. So we created this working model that perhaps it's this gradual loss of nitric oxide that causes insulin-resistant diabetes. Once you get diabetes, it further suppresses nitric oxide production, and that's why these patients spiral out of control. And they're poorly managed because nobody's paying attention to their nitric oxide. They want to give them glucophage or metformin or other types of drugs, but none of these affect nitric oxide. And I'm going to show you why they're missing the boat. We mapped out how insulin signaling occurs. We published this in 2014. So when insulin is secreted by the pancreatic beta cells, it binds to an insulin receptor and it initiates a series of protein signaling cascades, whether it's AKT, PI3 kinase, or the action of metformin activating AMP kinase. Well, both of these enzymes converge on eNOS to phosphorylate a certain serine residue that then turns this enzyme on. But in diabetics, we know that this enzyme is non-functional because it's uncoupled. So then this enzyme cannot produce nitric oxide, but that was the end of the story. Nobody knew what happened then. But we know that the terminal step in glucose uptake is GLUT4 translocation from the cytosol to the cell membrane, where it binds glucose and internalizes it. So what we did is we basically modeled this out, and we published this again in 2014, but nitric oxide can post-translationally modify 2 cysteine residues on GLUT4, and that's necessary and sufficient for GLUT4 translocation to the periphery to bind glucose and enhance glucose uptake. But unless you modify these proteins, which only occurs through nitric oxide or nitrite or some nitrosating agent like S-nitrosoglutathione, then GLUT4 never gets the signal, so you don't bind and internalize glucose. So this mechanistically explains insulin-resistant type 2 diabetes. It is a nitric oxide deficiency problem, and no drugs on the market are affecting this, and that's why diabetes is such poorly managed. But you can do this. You can enhance glucose uptake either in type 1 or type 2 diabetes, because this is the fundamental mechanism of glucose uptake that's dependent upon nitric oxide and post-translational modification of these cysteine residues. And then we moved into traditional Chinese medicine. So I had a cardiology fellow that was trained in China in traditional medicine, and he had an interest in trying to figure out how a lot of these traditional medicines or herbal extracts work that have been used for thousands of years in China. So it was an interesting enough project. So he spent several years in my lab as a postdoc. And so I sent him to a local acupuncture shop, and I said, bring back all the herb that you would treat a hypertensive or a patient with cardiovascular disease or hyperlipidemia. And so we brought these back. This is a table from our publication in Free Radical Biology and Medicine over 10 years ago. And so we ground these up with a mortar and pestle and prepared them like they did in the dispensaries in China. And then we put them in our nitric oxide analyzer. So this is actually nitric oxide gas that's being produced. And you can see some of the first extracts really didn't do anything. We put one in, and lo and behold, we could detect nitric oxide. And it gave us this predictable release profile. Then when we took the extract out, nitric oxide disappeared. We added another one, we get this spike, and then another kind of a very predictable nitric oxide release rate. And then so we rinsed that out, and I said, well, let's just add these two together to see what happens. And lo and behold, you get a synergistic effect. We could quantify the synergistic effects that's been described by these Chinese medicine for thousands of years by their ability to generate nitric oxide. So let me just explain here. If it was an additive effect, then you would expect you add these two together, you get about this twice as much nitric oxide. But it's synergistic. 1 + 1 = 10, not 1 + 1 = 2. And I thought, well, something's wrong here. Let's take it out, do it again. Boom, reproducible. Very predictable decay kinetics. If you were a medicinal chemist, this would make you extremely excited because you could dial in any level of nitric oxide you wanted based on how you combined these extracts. And so basically that's what we did. We isolated these. We didn't use traditional medicines because we found some herbs here in the US that were popular, and we could recapitulate this based on how we did this. So the next question was, if you're eating a good diet, vegetarian diet, plant-based diet, but everybody has a different oral microbiome. Some people are using antibiotics, antiseptic mouthwash. Some people are using antacids. So how can you overcome the variability based on differences in oral bacteria? So we used an old model in vascular biology where we could look at neutrophils and monocytes and T cells that when they begin to stick to the lining of the blood vessel, this is the start of cardiovascular disease, where your endothelial cells become like Velcro. Everything sticks, and then these cells will migrate through, and then this is where they elicit the oxidative stress and immune dysfunction. So elicit modified LDL. Over time, this foam cell plaque develops, and if there's inflammation, oxidative stress, and immune dysfunction, this plaque ruptures, and it's heart attack or stroke, and it's the end of the story. But it's also understood that if you can prevent the monocytes and neutrophils and T cells and platelets from becoming activated and sticking, that you can prevent vascular disease. And that's what we did here. So this is real-time intravital microscopy, 6 weeks of a really poor diet. This is a standard American diet. You can see it's inflammatory. You can see a number of monocytes and neutrophils that are sticking. There's a little bit of blood flow getting through here. There's a number of cells here that have already migrated through the endothelium. Excuse me. This is a heightened state of vascular inflammation. If we give that same atherogenic diet, but we employ these strategies to fix the nitric oxide production pathways, you can see here the blood vessel is more dilated. The monocytes and neutrophils home along the endothelium looking for sites of injury, but they do not stick and they do not migrate through. So even in the face of an atherogenic inflammatory diet, if you fix nitric oxide production, you basically inhibit the inflammatory response, the postprandial inflammation. And if you do this, you can prevent cardiovascular disease because these are the earliest steps in vascular disease. What about genetic testing? We're in this whole genetic era of we can test everything now. And now you can no longer blame your genes for your disease because we now know how to turn genes on and off. But I just want to show you one. As you all know, we simplify things in the basic science because most people only focus on, for instance, nitric oxide production. But you forget that these are cogs in a wheel, that if you disrupt something here, there's a buildup of metabolites or a breakdown of these cycles. The one I want to bring your attention to is the methyl tetrahydrofolate reductase, which in the American population, it's estimated to be 55 to 60% of the population. Well, this is more than a methylation defect, because if you look here, it's the MTHFR that takes biopterin and reduces it to tetrahydrobiopterin. And BH4 availability is the rate-limiting step in nitric oxide production. So if you have an MTHFR SNP, you're not reducing BH2 to BH4, and by definition, you become nitric oxide deficient. So MTHFR patients, by definition, become nitric oxide deficient. May not be obvious to everybody, but you can see how it fits within this metabolite shuttling. So hopefully I've convinced you that there's serious problems in the American population with nitric oxide, their nitric oxide production. A lot of it's self-induced, some of it can be genetic induced, some of it's lifestyle induced. But so when we set out to overcome this, we set out these 8 milestones to kind of give us a framework for developing a safe and effective nitric oxide technology. So number one, if your body can't make nitric oxide, we have to do it for you. Because you can, again, we know that giving arginine or citrulline doesn't work. Can't give nitrate because if you don't have the right oral bacteria, you're not going to get an effect. So if your body can't make nitric oxide, we have to do it for you. But we understand the enzymology of the NOS enzyme that we can recouple it and basically restore endogenous production of NO in the endothelial cells. Account for differences in non-responders to both nitrate therapy and L-arginine. We knew from our studies in traditional medicines that if we could make this plant-based natural product chemistry, that it's clean and testable. There's nothing synthetic there. This is what nature designed to do. We've just optimized it. Clear product experience. Demonstrate changes in vascular structure and function. Strong and sound basic science behind the technology. Clinically proven and peer-reviewed placebo-controlled clinical trials, and intellectual property for protection. And I can say we can check off all 8 of these over the past 20 years. And this is the product that I want to talk about and show you the clinical data on. This is available through Fullscript now, but this is a Neo40 nitric oxide lozenge. So this is designed to do 2 things. Number one, if your body can't make nitric oxide, this orally disintegrating tablet, when it's placed in the mouth, it's designed to have a 5 to 6 minute resident time because we controlled and determined the nitric oxide release profile. So don't chew it, don't swallow it, let it dissolve, because we basically recapitulate nitric oxide based production by the nitric oxide delivery. But then number 2 is we recouple the nitric oxide synthase enzyme. And I'll show you that you can take patients with endothelial dysfunction, and within 30 days, you can make them have normal endothelial function, showing that we recoupled the nitric oxide synthase enzyme and basically improve their body's own ability to make nitric oxide. This is the first study. This was published in 2011. So this just shows that if you put a nitric oxide analyzer in the mouth while the lozenge is dissolving, it generates nitric oxide. It's quantifiable, it's detectable, it's verifiable. No other technology on the planet does this. And then we see peak plasma concentrations within 20 minutes. And these are patients with endothelial dysfunction. This is an arginine-based product. And you can see there's no response, as predicted, because they have endothelial dysfunction. And this is a study done by Mark Houston at the Hypertension Institute in Nashville. You can see that within 20 minutes, 1 lozenge reduces both systolic and diastolic blood pressures by about 5 to 6 millimeters of mercury. And then 60 minutes later, there's a further reduction, statistically significant reduction in both systolic and diastolic blood pressure, where the placebo had no effect. 4 hours later, you see a 15% improvement in endothelial function. And this is flow-mediated dilatation using a device called the EndoPAT, which is basically ischemic hyperemia. So within 4 hours, we're recoupling and improving endogenous NO production. This is from 1 lozenge. And if you look at the carotid, 10 minutes after the lozenge, so we get baseline internal luminal carotid diameter of 0.52, give the patient the lozenge, 10 minutes later, we've increased the blood vessel diameter, the carotid, by 13%. If you use simple laws of hemodynamics, that's a 34% increase in blood flow. Do you think people that have an abnormal SPECT scan, whether it's alcoholism, ADHD, chronic concussion syndrome, or traumatic brain injury, if we're increasing perfusion of the brain? Of course we are. These are the big vessels. So everything downstream from there is going to get perfusion. And this is not just happening in the carotid. We can look at the femoral artery. We can look at any artery in the body, and we can see that this blood vessel dilation and improvement of blood flow and perfusion downstream. The next study was with Cedars-Sinai. Ernst Schwartz, a cardiologist, took pre-hypertensive patients, took 37 pre-hypertensive patients, and in 30 days, taking one lozenge twice a day, reduced their systolic blood pressure 12 millimeters of mercury, their diastolic 6 millimeters of mercury. So we took patients 138 over 84 on average, and after 30 days, made them 126 over 78. Took pre-hypertensive patients, converted 100% to normal tensive. No change in heart rate is very important. 6-minute walk test, the patients on the active were able to walk significantly further, showing a significant improvement in the functional capacity of the heart. And then a quality of life questionnaire, both physical and mental composite score. The patients getting the nitric oxide lozenge showed improvements in quality of life, where with a placebo, they actually got worse. Some other cool imaging modalities. This is a 49-year-old chronic smoker with Raynaud's. That's a microvascular disease. Cold hands, cold feet. You can see there's no heat radiating from the digits. 10 minutes after the lozenge, we open up the microcirculation and start perfusing the digits, complete symptomatic relief with one lozenge. This was a study conducted by Ed Lee, who's an endocrinologist in Orlando. Took 10 patients with stable carotid plaque for the previous 3 years, gave one lozenge twice a day, and within 6 months saw 11% plaque regression. If you compare this to statin therapy, as dangerous and bad as those drugs are, in 3 years you get about 2.7% plaque regression with all the horrible side effects. The NO lozenge, 11% plaque regression in 6 months. And the only side effect is improved sexual function, better blood flow, better perfusion. And then let me take you through one of the most gratifying things I've done. And this is where I'll bring in the genetics. This is an inborn heir to metabolism that these kids, that really most of them present to Texas Children's Hospital because they're the world leader in these inborn errors in metabolism. There's a group of kids that are born without this enzyme, arginosuccinate lyase. And if you remember back from the biochemistry, it's this partial urea cycle. So this enzyme converts arginosuccinate synthase, converts citrulline to arginosuccinate, and arginosuccinate lyase converts arginosuccinate into arginine. So when you don't have this enzyme, you get a buildup of arginosuccinic acid, and that's the basis of the diagnosis. It's a urea cycle disorder. Their primary problem is hyperammonemia. But these kids will die at 7 or 8 years of age from liver failure and cirrhosis if they don't get liver transplants. But even though they're managed pretty well these days with diet, protein restriction, and drug therapy to clear the ammonia, they still develop liver dysfunction. They develop blood clotting disorders. They develop neurological dysfunction that's independent of the recurrent hyperammonemia. They developed resistant hypertension, kidney disease. And so they came to me in 2005, 2006 to try to understand this genetic disease. And we basically recapitulated this in a mouse model, and we published this in Nature Medicine in 2011. But we discovered a new protein complex that the eNOS protein is tethered to the membrane through ASL. And so if these kids don't have this enzyme, this protein complex falls apart and they become completely devoid of nitric oxide production. And these kids are given about 20 to 30 grams of L-arginine per day to make up for their endogenous lack of production, but yet they can't make nitric oxide. Well, now this makes perfect sense because, again, they're not deficient in arginine. The protein complex that makes nitric oxide has fallen apart. And this is the lifelong blood pressure profile of this single patient. You can see at 5 years of age, he was put on prescription medication for hypertension. He did very poorly for 10 years. And in February of 2010, he came to Texas Children's, put him in the pediatric intensive care unit, 15-year-old kid. Blood pressure was 180 over 135. No medication would lower his blood pressure. We knew at that time it was a nitric oxide related problem. His physicians gave him isosorbide. He did well. Within 4 days, he was released and sent home, taking isosorbide 20 milligrams 2 to 3 times a day. He came back to Texas Children's almost a year later, taking 20 milligrams isosorbide 4 times a day. He developed tolerance or tachyphylaxis to these drugs, and his blood pressure was 180 over 110. We gave him the nitric oxide lozenge. Within 4 hours, his blood pressure completely normalized. Got him off all prescription medication. We're 7 years out, and he's off all prescription medication. Blood pressure's normalized. And within 5 months, his heart disease completely resolved. And you can see the the echocardiogram measurements here that he had a heart twice the size of a normal 15-year-old, but within 5 months of starting the lozenge, his heart had completely remodeled and was normal size with normal function. And now let me take you through just some cool 3-minute non-invasive FDA cleared devices that really give you an inside look into the structure and function of your blood vessels. So what we're looking for, type 1 blood vessels, that means they're soft, compliant, no plaque. They become elastic with each beat of the heart. They dampen the pulse wave. Where to the contrary, if you've got type 4, type 5 blood vessels, they're very stiff. So with each beat of the heart, that pulse wave travels really fast, damages the blood vessels, plaque, inflammation, oxidative stress, all the hallmarks of cardiovascular disease. And so this is just taken, we've had hundreds of patients now where we have data on. So this is a 74-year-old female, had type 5 blood vessels, did nothing more than put her on the nitric oxide lozenge, and within 90 days converted her to 100% type 1 blood vessels. 90 days, type 5 to type 1. And here's a 70-year-old female, type 4 to type 2 in 60 days. 60-year-old male, again, it's sex agnostic, this work. These are fundamental natures of biology. It doesn't matter if you're male or female. Again, hundreds of these. I just show you these as an example. And then let me move to this newest kind of project we've been working on, because to me this is exciting because we know how to make nitric oxide and we can now employ this technology across all market segments. And so I ask people all the time, nobody wants to get old, but I think the better question is, do you want to feel or look old? And so we can't do anything about the clock ticking, but we can affect how we look and feel. And this cannot happen without consideration of nitric oxide. And so I developed this dual chamber nitric oxide topical here that we've placed as a cosmetic or positioned it as a cosmetic, that when you combine these two components, they generate nitric oxide gas. So we can basically deliver nitric oxide topically and generate blood flow and perfusion to anywhere on the body where we want to apply this. And just let me show you how this works. I've got a quick video here just to show you. This is a nitric oxide analyzer. So I don't know if you could hear the audio there, but basically what we're showing is that when you apply this two components together, they generate nitric oxide. You can see wherever you apply this serum, there's an increase in perfusion to that area, and you can see that through the pinkness that colors it. So you apply these two, you generate nitric oxide that we can quantify, detect, and verify. But more importantly, you can see the effects of nitric oxide. So you don't have to guess if your cosmetic problem or your cosmetic product is working. You can actually see it working. There's no technology like this in the world. And these are just the before and after. So age spots, and these are all 30 days, applying it once in the morning, once in the evening to a clean face. This is a turkey neck. I mean, people have problems with this, but again, it's a blood flow problem. You lose when cells of the dermis don't get enough blood flow, they can't do their job. Cellular turnover decreases. You lose hydration, you lose collagen, and you lose volume. That's aging. That's fine lines and wrinkles. And so by simply restoring nitric oxide production to the outside of the skin, you can see that everything gets better. Complexion, tone, everything gets better. These age spots. Wound care. I mean, this isn't for a cosmetic application, but this just shows you what nitric oxide does. This is a partial thickness, really full thickness wound from a post facelift patient, and this is 10 days later. Simply restoring blood flow to that area, the body heals itself. Acne. inflammatory, ectopic dermatitis, any inflammatory condition. I've shown you with a video. Nitric oxide eliminates the inflammation. Acne, it's antimicrobial. Here's another. This was in 3 days. This is a 13-year-old female with severe acne. Within 3 days, we were able to clear that. And it works on all skin types, whether it's Caucasian, Asian, African American. You can see here within 30 days, things get better. And then let me show you the other really life-changing applications for nitric oxide that we're moving into now. This is my dad, who's been in a wheelchair for over 35 years from a car accident in 1984. Well, he's developed a lot of these decubitus ulcers, pressure ulcers, as most paraplegic diabetics. Well, he had a hemorrhoidectomy surgery, and a surgeon told him to go home and sit on a heating pad 30 minutes 3 times a day. And just for you physicians out there, never tell a diabetic paraplegic to go sit on a heating pad, because this is a full thickness 3rd degree burn that he couldn't even feel, but yet he knew he was burning. So this is a very grave prognosis here, very life-threatening, just because of the risk of infection from the location of this. Well, the surgeons told him that this would probably not heal. He would probably succumb to this from sepsis or infections. I refused to accept that, and this was probably about 7 years ago. That's what got me interested in a topical nitric oxide. This is post-skin graft. So I developed at night, when the nurses weren't looking, a nitric oxide releasing topical to restore blood flow to this area and to enhance the graft of this procedure. They said it would take 9 weeks to this to heal, if it would heal. This was 6 weeks later. Again, showing that if you apply nitric oxide topically, you can recruit blood flow and really change the course of these really dire patients. We grafted over that, but he developed these decubitus ulcers. This is osteomyelitis. For those of you that can't see this, this is a right ischial ulcer. Again, we employed the same strategies. Apply nitric oxide into this wound bed. This is today. We regrew tissue enough so that we could do a surgical flap, and we're 2 years out, and he's completely healed. When every wound care doc I took him to told me that this wound would never heal, because a 70-year-old paraplegic diabetic that's immobile by design, we could never heal this wound, and we can. This is my 8-year-old son, almost a full degloving of his right foot. From the time we got him from the accident to the operating room, this flap here had been detached for about 24 hours. Again, during the ambulance ride, I applied some nitric oxide to this. Primary closure, this was 4 weeks later. No plastic surgery, no loss of function. Today, you can't even notice that there's a scar there. So that just really shows to me very personal experiences that nitric oxide does some really amazing things. And it's not magic. It's basically utilizing the laws of nature and biology. So there are a number of products out there that are nitric oxide labeled. So let me just summarize this for you. Arginine utilization is controlled by the function of the NOS enzyme and not by arginine or citrulline deficiency. So there's nitric oxide products that have arginine, citrulline, watermelon extract, B12, vitamin C, all that on the label. They cannot and will not work in people with endothelial dysfunction by definition. Nitrate utilization is controlled by the amount consumed, presence or absence of nitrate-reducing bacteria. I would argue that over half of the population don't have the right oral bacteria. Stomach acid production, 70% of the population doesn't have right stomach acid production. So these products won't work. Potassium nitrate in a capsule will not work in the majority of the population. And this is physiology. We know this. And so I compare it to thyroid hormone. And this drives me crazy, because people with hypothyroidism, you go to the doctor, they give them T4, levothyroxine synthroid. That's an active hormone. It has to be metabolized into T3. Most people are deficient in iodine, so they can't convert it to T3. Same thing with nitrate. You can give them nitrate. You can eat a good diet. You don't have the right oral bacteria, stomach acid. It's inert in humans. So these are basic laws of physiology. So nitrate does not equal nitric oxide. And so you can disrupt this pathway by, number one, not eating enough green leafy vegetables. But again, as I showed you, you can eat plenty of green leafy vegetables. If they're organic, you can't get enough nitrate. Insufficient saliva production, Sjogren's syndrome, prostatectomy patients. Again, antibiotics, over 200 million prescribed every year. Antiseptic mouthwash, 200 million Americans every day wake up and use mouthwash. Poor oral hygiene. What I didn't tell you is people with active oral infections, periodontal disease, gingivitis. The bad bacteria outcompete the good bacteria. and then insufficient stomach acid production. There's over 200 million prescriptions written for PPIs. That's not even counting the over-the-counter ones. So I think the numbers are even more. So you're confused. I'm confused, and I've been doing this for 20 years because patients can look at this and go, what do I take? You as physicians look at it and go, what do I recommend? It's confusing because in the supplement industry, everybody can say the same thing, but only one product works. So let me just leave you with this. Beets do not equal nitrate. There are dozens of beet products out there that have beetroot extract on the label. 90% of these don't contain any nitrate. It's just used as window dressing. And perhaps most importantly, nitrate does not equal nitric oxide. Because of the antiseptics, antibiotics, and PPIs, most people, the majority of Americans, cannot convert it into nitric oxide. Arginine citrulline products do not work in patients with endothelial dysfunction. So what to look for in product technology? Look for issued patents. This demonstrates there's innovation and uniqueness, that we've been able to do something that no one else has been able to do. And because there's patents that no one else can do. Look for published clinical trials in peer-reviewed journals on the actual product. Clinical trials in humans cost tens of thousands and hundreds of thousands of dollars. Most dietary supplement companies will not put their product through a randomized placebo-controlled clinical trial because it's very expensive and they know they're not going to get the result that they want. So it's wasted money. Look from, it's licensed from a reputable university. So you may not have patents, but at least there's been some research done on it that demonstrate that there's something viable there. And then this is very personal to me because big pharma, and I've consulted with many big pharma, for 40 years they've tried to develop safe and effective nitric oxide therapeutics. Do you think somebody off the streets for some supplement company is going to suddenly have an epiphany and come up with a nitric oxide article or a product? There's lots of webinars now that I see, and I get invitations of them. I go on these webinars, and they're using my slides, my exact sentence structure, and I do a PubMed search, and these people have never even published a single article on nitric oxide. So I encourage you, do a PubMed search, put the names in there of the person doing the webinar, and if they have never had a peer-reviewed published article on nitric oxide, they're no expert, and they certainly don't know the enzymology and biochemistry to the extent that they can develop a safe and effective nitric oxide product. So the most important thing is don't be fooled by creative marketing. Science and experience matter. I've done this for 20 years. That's all I've done. And so you're busy seeing patients running an office. Let us do diligence for you. So FullScript's a great partner because it gives us another kind of way to screen products. They provide a credible and reliable product source for your practice. If a product is not offered on FullScript platform, then it's probably not met the scientific and clinical rigor to do what I just told you to do. Look for patents, look for clinical trials, look for the science behind it. If they don't offer it, then I think that's enough said that it's probably not a very good product if it's not on their platform. And then trust the people that have actually done the research and have published in the nitric oxide field. So let me just conclude. I think I've got a couple minutes left. Hopefully I've convinced you nitric oxide controls and regulates vascular structure and function. There's an age-related decline in nitric oxide production that asserts its effect on cardiovascular risk and really all age-related disease. Restoring NO production can lead to better vascular function and better perfusion of all tissues. Strategies to restore NO production or homeostasis will have a profound impact on public health and on the aging process. And most importantly, your patients cannot and will not heal or get better without restoring nitric oxide-based signaling. It's fundamental. Folks, this is a new discovery in medical literature. It's only 30 years old at best. This takes time to teach and to learn and to be adopted and accepted by not just consumers, but by healthcare practitioners. And that's why I think it's important, and I appreciate the commitment and time that you're actually spending today to learn about this, because you will see a dramatic impact in the outcome of your patients.